So I'm just going to give you a little overview about principles of management of thyroid oncology, and I'm going to touch a little bit about both the medical and the surgical perspectives, and what is the role of you as an ophthalmologist when you are encountering this patient. What should we really be telling your endocrinologist about how they should be managing the thyroid problem, underlying hyperthyroidism, hypothyroidism, or whatever it is. Or even if you cannot tell them what you want from them, you should tell them what stage of orbitopathy there is and what you're going to be doing for the orbitopathy so they can help it. They can in turn help co-manage some of those as well. Okay? So as we have discussed, it's a very common disease, yet poorly understood disease by us clinicians. We know that ophthalmopathy is in a way slightly indifferent of hyperthyroidism, evidently seen by patients with euthyroid Graves' disease. So there's no hyperthyroidism there, and it still has significant orbitopathy. So there's a mismatch over there as well. We all know that this is primarily a medical disease now, should be managed medically in the earliest stages of the disease. So much so that by the time they come to us with blood retraction, they may already be going through the fibrotic phase of the disease, which I think is probably no longer an early presentation but late presentation. And finally, not just the physical morbidity, but the emotional and social complications as well. Beautifully illustrated before was the concept of activity and severity. That's something that you take home today. That's enough, because that's what is going to lead towards the management of the disease. The examples of two patients in the bottom who's got mild but active disease. Look at the congestion, look at the redness, look at the recent onset of retraction, clinical activity score that Dr. Sundar talked about. So if you meet more than 3 of the 10 criteria, generally you think that some inflammatory activity is going on, as opposed to inactive disease is burnt out disease. But you may still have gravitational disease, like in that patient who's got severe exposure to atopy. He no longer has active changes going on, active inflammatory changes going on, but the residual disease with severe exposure which requires intervention, which by definition becomes severe disease itself. Yet again, examples of patients who are mild, very early lip retraction, minimal chemosis, moderate disease doesn't bother them too much to wake up with a little bit of puffiness, swelling, disabling them, consciously thinning with the eyes. And severe disease are patients like these. And in my definition, severe disease includes not just exposure keratopathy and compressive optic neuropathy, but even disabling diplopia within the primary gaze or within 30 degrees of fixation, which is very, very important. There's a classic clinical examples of severe disease: severe proptosis to exposure, apical compressive optic neuropathy, and disabling diplopia itself. Beautifully talked about the Rundle's curve. Why is it very important that you understand and put the patient where they belong? Because if you're going to be intervening medically, you want to intervene there. Not really much of a point intervening there medically, because they burnt out disease, where even left alone they may get better on their own. And absolutely no point intervening medically at this late stage disease. So putting them on the Rundle curve at any one point of time is very, very important. And the evidence is, if you're able to intervene early, you may not be able to completely prevent all the changes, but at least we hope that we end up reaching a much lower peak. So the degree of residual damage we're going to have is going to be much less. And that's the driving principle about the medical management of the disease. So you talk about medical management here, this is what we're talking about. Management of the underlying hyperthyroidism, although ideally, yes, the endocrinologist is doing it, but half the time they may not understand why you want them to do a particular thing. And you should also understand what's going on, and the management of the orbitopathy or the ophthalmopathy itself. Very unusually, patients get observed for hyperthyroidism. If you have clinical hyperthyroidism, remember it's not the T3, T4 which is important, but the TSH levels which tells you whether the patients are really hypo, or euthyroid. Keeping in mind that once you start treatment, it takes quite some time for the TSH to stabilize. So when you start treatment with antithyroid medications, don't wait for TSH to come back to normal immediately. And that's why it's very, very important. We'll talk about when endocrinologists, antithyroids, when you could consider radioactive iodine, and finally the role of surgical thyroidectomy, and then finally we'll go over a little bit more of this in detail. Conservative management, this is the role of steroids, other non-steroidal agents, and finally surgery itself. And this again drives some of the concepts like our lacrimal talk we gave a little earlier on, multidisciplinary clinics. We run a thyroid clinic with our endocrinologists, with an immunologist, and occasionally a stomatologist as well. When we have patients with diplopia, you are making joint teams together, partly to understand what the other party can do, but partly also for the patient to understand and to get a holistic approach in terms of recommendations for management. So how do they manage hyperthyroidism? Traditional standard way of managing is antithyroid drugs. The various groups of drugs which I read about, and that becomes the gold standard of treatment. But when we start considering other alternative treatments, if somebody's on anti-thyroid drugs for 2 years, 3 years, 4 years, we've had patients who even had anti-thyroid drugs for 20, 30 years, or anti-thyroid drugs who develop secondary side effects like neutropenia, pancytopenia, and all this stuff. That's when you really start thinking about other alternatives. So, bottom line, anti-thyroid drugs is the way to go. If they start developing allergic reactions, or they end up on anti-thyroid drugs for 20, 30 years, you realize that you may have missed the boat and you may want to think about some definitive way of managing it. And that's when radioactive iodine and surgery kind of comes in. So it is yet still controversial precisely because of the point Dr. Sampath drove in. If somebody's got active inflammatory orbitopathy, already is compromised visually and functionally, if you give them radioactive iodine without the steroid cover, they're obviously going to get worse. So avoid radioactive iodine in patients who have active orbitopathy, but if you do not have any other choice, you can cover them with peri-radioactive iodine steroids. I usually start them 2 or 3 or even a week before radioactive iodine. Continue the course of steroids for 3 or 4 weeks, and once you've demonstrated no flare of orbitopathy, you can kind of take it as well. Because if you don't cover active orbitopathy patients with steroids, you are going to develop exacerbation of disease. So that's a driving principle in the role of your ophthalmologist when patients are getting radioactive iodine for hyperthyroidism as well. Okay? And I think this is a classic example of a patient who never saw an ophthalmologist when he got the radioactive iodine. So most patients in our practice, before radioactive iodine is referred to us, for us to categorize them as active or inactive disease, as a mild, moderate, or severe disease, then we make a recommendation. Radioactive iodine contraindicated. No, radioactive iodine can be given, but you may want to cover them with steroids, or you may say there's no ophthalmopathy at all. Go ahead with radioactive iodine. We'll monitor the patient along for flare-up as necessary. Okay? So how do we manage ophthalmopathy? A lot of times, simple things make a big difference. Even elevating the head of the bed, because it's a congestion they develop early in the morning when they wake up. They have diplopia in the morning when they wake up in the first 2-3 hours. Exactly the opposite of myasthenia gravis, where they don't have diplopia and then in the next 2-3 hours. And that's something where, again, elevating the head of the bed is very, very useful. Protecting the eyes, goggles, both indoors and outdoors, will be very, very useful. And lubricant therapy as well. So these are things that we always have in our hands. But what is a no-no is patching the eyes. You tell these patients to patch the eyes. Where do the patch sit when the eyelids go into retraction and sleep at night? Right on the cornea. So definitely in my book, patching is contraindicated in patients with lag of colors and exposure retinopathy. You should be thinking about other modalities of covering. I use tegaderm wraps, which actually works very, very well as well. And smoking, absolutely no-no. And invariably, you will realize a lot of these patients are smokers. And I've adopted a slightly different strategy to smoking. I used to tell them in the past, quit smoking, go tell a drunkard to quit drinking, he's not going to do it. I give them realistic targets. I give them, if somebody's smoking 10 sticks a day, by the time you come and see me next, you should be down to 10 sticks. Then over a reasonable period of time, I tell them come down to 5 sticks, 1 stick, and so on and so forth. That gives them more of a realistic goal to achieve rather than completely asking them to stop smoking, because they stop for a few days, they cannot go back to smoking and they've given up as well. Okay, so chance does harm. Okay, keep that in mind. So I will skip that. And then for active disease, what do? That's where the immunological interventions comes in. Steroids are the mainstay of treatment, but not the way we've been doing in the past with oral steroids. When steroids fail or they have side effects, that's when you think about non-steroidal alternatives and immunosuppressants and immunomodulatory agents. So in the past, we were giving a lot of oral steroids for months to years. Patients were on it, and they were elderly, post-menopausal, they were developing osteoporosis. They didn't have diabetes before, they would develop diabetes, they would become Cushing-Boyd, and all those consequences as well. What has changed with steroids is the role of parenteral intravenous methylprednisolone. There's a lot of controversy about the regimen and the dosing. I'll share with you my personal perspective, but then you can learn as we go along as well. We'll talk about how we give steroids as well. In patients where there's a contraindication for systemic steroids, or there's a diagnosis and doubt whether it's active disease, inflammatory disease causes congestion, or is it a pure venous stasis, congestive orbitopathy, then there's a role for periorbital steroids more as a therapeutic and a diagnostic steroid. And we learned a little bit about how steroids work based on pathogens and disease as well. Okay? So, oral prednisolone, yes, it is effective. but the consequences and side effects are quite severe, and it's been shown that when given very high doses of IV methylprednisolone, the efficacy is the most maximum. So hence we are gravitating towards that. You should be aware of the complications of steroids, and the major criticism against intravenous high-dose methylprednisolone is the potential that you can kill the patient if you have not adequately screened the patient. So they get a complete steroid workup, including liver function tests and hepatitis serology. If they have compromised liver function, they are not candidates for IV methylprednisolone. But thankfully, most patients who do not have liver disease, do not have other comorbidities, are ideally very good candidates for IV methylprednisolone. The other potential cause for death in IV methylprednisolone is cardiac arrhythmia, which occurs during the time of infusion. So we've moved away from IV pushes of high doses to slow infusions, which is anywhere over 45 minutes to 2 hours infusion. And if they were to develop an arrhythmia, it occurs during that time, your nurse picks it up, you manage, and thankfully it's not a problem. And typically it usually happens in patients who are heavy smokers as well. That's why co-managing the smoking alongside these things is very important. So barring these two side effects, having methylprednisolone is very safe. Okay. So to me, in my book, contraindications for high-dose steroids are uncontrolled diabetes. Diabetes per se is not a contraindication for steroids in having methylprednisolone. These patients are being co-managed by endocrinologists, they can take care of it. If they have had any recent hepatitis or significant liver dysfunction, that becomes a contraindication for these IV or high-dose steroids as well. And of course, any underlying other problems as well. However, when patients have no contraindications at all, we tend to give what is a high dose. We don't give mega doses like intravenous optic, which varies anywhere from half a gram to 1 gram a day. The equivalent of 1000 milligrams a day dose is 1000 milligrams of prednisolone. So you're really hitting them hard. But it's like violent terrorists. Sometimes you want to hit inflammation hard, get the inflammation under control, then you start managing these diseases as well. But you have to remember at no point of time should you have accumulated doses of more than 8 grams. Because that's when all these other major complications occur. So if you're able to space out the dosing and monitor these patients, steroids are fairly safe, even given in high doses as well. Okay? We don't need to admit patients anymore. In most institutions, we now give it as an outpatient setup, like outpatient antibiotic therapy, outpatient infusion therapy, and if you work with the rheumatology colleagues, they will give these as an outpatient treatment. Okay? So I give anywhere from 500 to 1000 milligrams a day for 3 days, and usually evaluate the patients 2 to 3 weeks later. If the diagnosis is right and what stage is right, active disease, these patients should have subjective and objective improvement in the dose of steroids, which then leads you on to further management. Generally, when patients are categorized as active inflammatory orbitopathy, which is moderate to severe, I give a gram a day for 3 days, no treatment for the next 3 weeks, evaluate them, monitor for side effects, no side effects. They get anywhere up to 3 to 6 cycles, and then you decide whether you can stop the steroids, or if they have progressive inflammatory disease, you talk about. There's a taxi driver who actually, look at him, does not seem to have significant disease, but he's got double vision. Try getting on a taxi where the taxi driver has got double vision. So he underwent IV methylprednisolone treatment, and look at the subtle, yes, significant, both symptomatic and objective improvement in IV methylprednisolone as well. Here's another lecturer, new onset Graves' orbitopathy. So look at the wet congested diaphragm. So what we're now doing is lowering the threshold for steroid intervention. And look at the same patient after 3 to 6 cycles, significant improvement in these patients. And if you have to be a patient to really suffer from thyroid orbitopathy, to really see. So what we're doing is defining specific indications as contraindications, and we're doing more for these patients as well. And when steroids fail or do not work or they develop side effects, that's when you can resort to any of these immunosuppressants. We're working with the immunology colleague. It's very important. If you look at the evidence, the literature, there's no one particular immunosuppressant necessarily better than the other, and the immunologist may have a favorite. Here's another patient who's starting to show very well congestive disease, proptosis. Same thing, completely quiescent after a dose of steroids, followed by immunosuppression for 12 to 18 months. And finally comes radiation. I generally do not like to use radiation because we now know that radiation is bad. That's one of the reasons why we don't casually do CT scans as well. But the indication for radiation is when the patient is not a candidate for any of the forms of immunosuppression. But the contraindications are elderly patients, diabetics, and hypertensive, they have microvasculopathy on top of it, especially a pre-existing retinopathy in bronchial radiation. Okay, so in my book again we do that. What evidence seems to suggest is radiation doesn't work alone. It works very, very well when it's combined with steroids. So once again, looking at the radiation immunological profile as well. Okay. So let's go into surgical management. So this is the paradigm I use for thyroid eye disease. First, if it is indeed thyroid eye disease, you want to label them as active or inactive disease. If it is inactive disease, no role for steroids or any immunosuppression. This active disease, yes, then you look at whether there are any contraindications to steroids. If there's no contraindications to steroids, then you go for treatment. But there's absolute contraindications, that's when you consider either radiotherapy or decompression. So they are moderate to severe disease. I gave them high doses steroids and 3 to 6 cycles. They're refractory, then they get other immunosuppression. And lastly, again, radiation therapy or decompression when again it will work. But when they have inactive disease, it's mild disease, most of the times it's conservatively managed. But it's moderate to severe disease, severe proptosis, even exposure keratopathy can be inactive disease. There's no inflammation going on. It's only lack of thermistic exposure. That's when you start thinking about surgical management or true active disease of compressive optic neuropathy, like somebody showed earlier on, where you go to decompression. So the next 5 minutes, I'm going to give you outlines of principal management. Combination of surgeries include decompression, which we all talk about, and followed up by strabismus surgery, information will be complex about it, and finally the flag on the kick, and that is a lid retraction repair. A lot of these patients can benefit from other procedures, including punctal procedures, mini lateral calcifications, and Botox as well. Okay? So about 20% of patients, even when properly managed, will require some form of decompression, keeping in mind that this is not for compressive optic neuropathy or severe exposure alone, even for cosmetic decompression. So the threshold keeps going down for decompression itself. The probability increases as the patients grow older, more likelihood that men with the grace of neuropathy is going to require surgical management than women. And in the past, the standard teaching is decompression should be followed by strabismus surgery, should be followed by lid surgery. But every once in a while, with better techniques of orbital decompression, minimizing the chances of new onset strabismus, we can actually now, in a way, consider eyelid surgery in select patients as laparotomy along with decompression, possibly giving patients even a one-stage surgical management. It's easier said than done. It does not always work, but there's a role for it as well. Okay? So decompression can be done as an elective procedure, which is a lot of patients, or very rarely is an emergent procedure. We've got pulmonary compressive optic neuropathy, not a candidate, and the patients don't have time for immunosuppression as well. And you can do 1, 2, 3, or 4 walls. And standard teaching used to be said 1 wall is 2 millimeters of decompression, 2 millimeters of proptosis reduction. It does not work that way, at least in my hands. Okay? You can either do a wall, which is bone alone, or fat alone, or more often than not, you do a bone and a fat decompression. The concept of orbital decompression is if you have a heavily loaded truck, okay, the solution will be either to decompress people, so throw people off the truck, or you build a bigger truck. And that's what we do with orbital decompression. Fat decompression, we are offloading contents of the orbit. With a bone decompression, we are building a larger wall for the orbital contents as well. And these are the various indications for orbital decompression. You can do one wall alone, which could be either a medial wall or a lateral wall alone. Generally, we use a medial wall for compressive optic neuropathy. Lateral wall is not for compressive optic neuropathy, but you want to get anywhere from 3, 4, 6 millimeters of decompression. We tend to use a 2-wall decompression as a shift towards quote-unquote balanced decompression. It's not as balanced as it's claimed to be, but a combination of medial lateral wall leads to better results than the traditional anterior decompression, which gave a lot of nuances to business as well. Very rarely we do 3-wall decompressions, but they're still reserved for patients with severe proptosis and finally fat decompression. And I think we talked about this already. Okay? So medial wall decompression is something where you want to get the optic nerve. You want to get a posterior medial wall. So decompression for compressive optic neuropathy is very different from decompressing for proptosis. For proptosis, you're aiming at a target at the equatorial zone, and for optic neuropathy, you're looking at the apex of the orbit, right? Exactly where you want to be. And this can be done either transconjunctivally or endoscopically as well, and it's very, very effective for compressive optic neuropathy. We sometimes resort to medial lateral wall decompression as in these patients with these. where you're looking at the lateral wall of the bone, the diploid space in the lateral wall of the orbit, and the thicker the lateral wall of the orbit, you're going to get a very good response to lateral decompression. In other words, not all patients are good for lateral wall decompression itself. Okay? Here's examples of deep lateral wall, thick bony cavity, and you literally have to go up to the temporal lobe of the brain. You want to see dura, obviously you don't want to reach dura and cause a serious leak, and that would be a good lateral wall decompression candidate patient as well. There are various approaches which can be done. Generally, we use periorbital approaches, a swinging eyelid approach, kentotomy, canthalisis, is used for everything else. But of course, there are groups in the world which do a coronal approach as well, which I don't do that at all. Okay? And I'll probably finish in the next minute or so. So these are the various approaches: swinging eyelid approach, endoscopic approach, confocal lock approach. We don't do anymore, and we don't do anterior decompression. Here's an example of a patient who's had a lateral wall and a medial wall decompression. The advantage is reduces the incidence of post-op strabismus for these patients as well, down to about 15 minutes. When do we do fat decompression? I call them the Hollywood decompressions. I don't have patients who come with 2 millimeter proptosis. I have patients who have significant proptosis, and you want to identify the patients. You want to identify patients who do not have permanently enlarged muscles, but predominantly fat volume increase. And those are the patients who are going to be doing very well with fat decompression, and we know that the adipocytes have changed. And you can get anywhere from 3 to 5 cc's of fat behind each arm. So this is how I measure fat after I do a decompression. Sometimes I calculate ahead of time and I'm able to deliver. It will not work for the hard fibrous 2D orbits as well. Okay? Keeping in mind that fat acts as fat absorbers, so there's a little controversy about it. So here are examples of patients who have undergone fat decompression, and we can actually do simple anterior blepharoplastic approaches. Some people do it under local anesthesia, but generally do it under general anesthesia as well. So in summary, the way you manage the patients is when you're talking about various forms of treatment, you're customizing treatment to the patient. And if you have very mild proptosis, I do fat decompression alone. If you have moderate proptosis, I do a single wall, which is a lateral wall and fat alone. In the right patient, a thick lateral wall. And if you have severe proptosis, that's when I do a balanced decompression, medial lateral wall decompression and fat decompression. If somebody's got a pre-existing diplopia, in pre-operatively, I go all the way to a maximal decompression when I can before I hand over to this to be smaller this. So I'm going to hand over to Dr. Ramesh Murthy, who's going to talk to us about diplopia management in the previous hospital. And we can have time for questions towards